with the first modern world publication coming out in 1951 from Allen and Hines. Lipedema is a chronic and progressive disease almost exclusively affecting post-pubertal women, with some figures suggesting a prevalence of 10% of adult women in Western countries. It is characterized by disproportional and symmetrical accumulation of subcutaneous fat tissue in the upper and lower extremities. Although the pathophysiology of lipedema is still up to this day unclear, histomolecular studies have shown changes in the adipogenesis as well as in the lymphatic microcirculation. Due to the high prevalence of thyroid disease, as well as puberty and pregnancy acting as trigger points, we also suspect a possible link to hormonal dysregulation. Still, we have no definitive chemical or imaging biomarker to assist in diagnosis. In Potsdam, we refer to lipedema as a syndrome, seeing that there are typical signs and symptoms which are associated with it, such as easy bruising, a permanent sensation of tension, and disproportionate pain upon touch. Patients also typically report a general impairment in walking, exercising, as well as an impaired quality of life, leading to a substantial psychosocial burden. Stage 1 lipedema typically has a relatively smooth skin surface with a uniform thickened fat layer. In stage 2, the skin surface becomes uneven with a nodular fat layer and frequent depressed areas, the so-called mattress phenomenon. With disease progression at stage 3, the nodular tissue becomes firm and we see the formation of the typical folds of excess skin and fat. Here, we're marking the patient while standing to get a better appreciation of the problem areas, especially around the knees and the ankles. Many patients develop obesity as well as osteoarthritis secondary to lipedema, possibly as a result of the fat deposits around the knees and ankles, leading to a mechanical obstruction during walking. As such, we give this area special emphasis during the operation. Another very often seen comorbidity is thyroid disease. Although we suspect a pathophysiological correlation, this has not been definitively proven. Interestingly, prevalence of metabolic diseases such as diabetes and hypertension is distinctly lower than in non-lipedema obese women, suggesting that although a link exists between lipedema and obesity in later stages, they are two separate disease entities. Conservative therapy with manual lymphatic drainage and compression garments is first-line treatment and can delay the disease's progression. It doesn't, however, necessarily stop it. In the multimodal therapy of lipedema, we also give special emphasis in psychological support as well as nutritional advice. Although no universal lipedema diet exists, we advise our patients a balanced diet with a goal towards BMI reduction. All of our patients have been diagnosed with lipedema through a specialized lymphologist, as well as have gone through at least 6 months of conservative therapy without improvement. We advise all our patients to begin an iron and vitamin B complex substitution therapy before the operation to allow for a quick post-operative recovery. Seeing that we are conducting mega liposuctions, also known as large volume liposuctions, all of our lipedema patients are treated in an inpatient setting and the operation is conducted in general anesthesia. A single-shot antibiotic is given before starting the operation. A major difference to aesthetic liposuctions is that in lipedema, we generally need to use a large number of incisions to be able to remove sufficient fat tissue. We do try to place the incisions at as discrete positions as possible, but here volume of fat removed takes priority over discreteness of incisions. Here, we're infiltrating the subcutaneous tissue with tumescent solution containing epinephrine for vasoconstriction, thereby allowing liposuction of large volumes. Paramount is an exposure time of about 30 minutes before beginning with the liposuction. This makes the procedure much easier by facilitating detachment of fat from the surrounding tissue. Although we have used both vibration-assisted and water jet-assisted liposuction in the treatment of lipedema, in Potsdam we generally prefer vibration-assisted liposuction. The operating team consists of at least 2 surgeons working parallelly, again for keeping the operation time as short as possible. In the surgical therapy of exophthalmos device from Professor Olivari, The removal of orbital fat tissue from specific compartments helps alleviate the increased intraorbital pressure, leading to symptom reduction. Through our ongoing MRI study of lipedema patients before and after surgery, we have divided the subcutaneous tissue into 3 compartments, separated through a superficial and a deep facial layer. If the patient's size allows it, we begin with a 5 mm aspiration cannula to debulk the deep tissue between these 2 facial layers. We then switch to a 4 mm aspiration cannula to remove the more superficial fat. Currently, there is no universal standardized strategy in the surgical treatment of lipedema. Our own concept in Potsdam consists of 3 important parameters. Firstly, liposuction is carried out with 3 different cannulas, 5, 4 and 3 mm in 3 different compartments. Second, we always direct our cannula in a lymph-sparing axial direction and avoid crisscross liposuction. Lastly, we carry out large volume liposuction, removing up to 10% of total body weight. We switch to a 3 mm aspiration cannula and go right under the skin so as to stimulate skin retraction. Now comes the pinch test, where we check for symmetry. We are generally satisfied with a pinch test of less than 2 centimeters. Once we have reached our goal, we begin with mechanical tissue modeling as well as cooling, with the patient still on the operating table. The goal here is swelling reduction and lymphatic drainage. We suture the incisions closed to avoid excessive post-operative fluid discharge. The compression garments are put on while the patient is still on the operating table to decrease post-operative swelling. By allowing sufficient exposure time to the tumescent solution after infiltration, we improve the quality of lipoaspirate and avoid a sharp decrease in the patient's hemoglobin levels. We ensure a short inpatient stay by instructing the patients to mobilize as soon as possible after the operation. No antibiotics are given in the post-operative period. We begin with manual lymphatic drainage from the first post-operative day and instruct the patients to wear the compression garments for at least 6 weeks, day and night. Although complications after liposuction in lipedema patients are rare, we do sometimes see a marked post-operative hematoma formation, prolonged post-operative swelling, and very rarely disturbances in wound healing. We also expect a drop in hemoglobin levels, which can in very rare cases lead to the need for a blood transfusion. In our experience, although large volume liposuction in lipedema is a safe procedure, we still believe that each operation should be conducted in an inpatient setting with the possibility of intensive care for the patient. In Potsdam, we begin the surgical treatment of lipedema with the liposuction of the front side of the legs. Then comes the back side with at least a 3-month interval between each operation. Up to 50% of our lipedema patients have typical lipedema symptoms, also affecting the arms. If this is the case, after the legs comes the liposuction of the arms. The number of rounds of liposuction, as well as the amount of lipoaspirate, generally leads to a substantial amount of excess skin, and considerable amount of our patients, usually the younger ones, commonly seek a removal of this excess skin. This can be in the form of a thigh, arm, or a total body lift. We wait at least 1 to 2 years after the last liposuction before undertaking a lift operation to see how much of the skin will retract by itself. In trying to better understand and treat lipedema, we have created the Potsdam Lipedema Research Group. Our group consists of physicians in the field of plastic surgery, angiology and radiology, study nurses, medical technical assistants, as well as researchers with a primary interest in the field of adipocyte development and nutrition. Through our collaboration with the German Institute of Human Nutrition, we're looking into any aberrations in adipogenesis. Through our ongoing MRI study, we're searching for a possible imaging biomarker which could assist in the diagnosis of lipedema. We're also currently in the process of initiating a prospective randomized study comparing water jet to vibration-assisted liposuction in treating lipedema. Through a retrospective analysis of our records of the last 10 years, we conducted a total of 271 liposuction procedures in 102 lipedema patients. The amount of some lipoaspirate per patient was 15,250 ml. The great majority of the patients reported a significant improvement of lipedema-associated complaints as well as quality of life after surgical treatment. Furthermore, the need for conservative treatment was significantly reduced. Another important aspect is that better results were achieved when surgical treatment was performed at earlier stages. 99% of the operated patients were satisfied and would recommend liposuction as a treatment modality for lipedema. We have completed the retrospective evaluation of our data and are in the process of submitting for publication. Liposuction in lipedema is a form of functional therapy. On the other hand, aesthetic liposuction usually involves removal of only small fat volumes. Incisions need to be placed at very discrete positions, preferably locations which are easily hidden with clothing or underwear. Water jet-assisted liposuction can also be used according to the surgeon's preferences. Lymph-sparing axial direction is not as of great importance as in lipedema. Much more attention is paid to the aesthetic outcome. This, combined with only a minimum amount of incisions, means that crisscross liposuction is commonly utilized. Lipedema and its surgical therapy is currently a very intensely debated subject in Germany. The GBA, that is, the Federal Joint Committee in Germany, has announced that beginning from the 1st of January 2020, the cost of liposuction in lipedema stage 3 patients will be covered from the patient's state-mandated medical insurance. There will also be a randomized, controlled, multicentric study comparing conservative to surgical treatment of lipedema in order to shed more light on the benefits of liposuction as a treatment modality in lipedema patients. As an important take-home message, we would like to emphasize the need for correct patient selection and wish to reinforce the concept that after insufficient symptom reduction with conservative therapy, liposuction should be considered therapy of choice in lipedema. Thank you for your attention, and we hope to see you all in Potsdam for the annual conference of the German Association of Plastic Surgery in 2021.